Okay, so let's just move on to the next slide here. And as we continue to talk about nitric oxide, these are some of our concerns. As I said before, anytime the nitric oxide combines with the oxygen in the circuit, then it's going to form NO2, and that's when it becomes toxic. So then what we do is we always make sure that there's proper gas flow, and that helps to kind of keep those levels of NO2 lower. And then also that gas injection module that's coming from the Inovent, we try to get it as close to the patient as we can. So that's another way of minimizing the amount of time that the nitric oxide has in contact with the O2. And then the ventilation system, again, there's so many people that have said one thing versus the other thing, meaning that sometimes they felt that it's always a concern that the healthcare workers may be accidentally exposed to this nitric oxide as it's leaving the system that you're using. Say, like for instance, if you're back to this example with the baby, this oxy hood is open, meaning that what's stopping it from getting into the atmosphere? And if you're taking care of the baby, then you're possibly being exposed to this nitric oxide. And the same would go for a ventilator. If this was a ventilator patient, you know that once the breath has been delivered and the patient exhales it back out, now it goes through the exhalation side of the circuit and it goes through usually a filter and then out the exhalation on the side of the machine or on the back of the machine or somewhere. And then there's still a concern that maybe the nitric oxide is still there in the exhaled gas that's now in the room. So your hospitals are usually pretty good about making sure that their HVAC systems, their heating and ventilation systems are way beyond code as far as like hospitals ventilation systems has got to be a whole lot more effective than any other building. And so that's usually, again, not our concern, as long as that system is working the way it's supposed to. And then some hospitals go even a step further and they provide what's called a scavenging system. Uh, and the whole point of this is to so this scavenging system will be some way that you can connect. It's in the wall, like some kind of valve or connection or something that you can connect to your system, so that way it will literally take care of any exhale gases. ORs, they have a dedicated scavenger system for each OR suite, and the anesthesiologist, of course, is using it to vent out all these different anesthetic gases that they may be using for that particular case. Now, will your ICUs have this? Not necessarily, unless the hospital made sure that they had it in their design when the hospital was built, that all ICUs should have also their own scavenging system. So that way, if you're going to have to do something like nitric oxide therapy at the bedside or some other kind of like gas therapy, that might be considered to be almost like a safety concern, especially when it comes to your OSHA regulations, then they may actually invest in something like that. But in general, as long as you're ventilation system is fine, then we're usually okay. Our concern is really when we're in a really small confined place. Like the very last chapter that we talk about in this course is transport. And this is, of course, we're talking like transport from one hospital to another, like usually like a helicopter or airplane or whatever the case is. If you're in one of those little tight spaces and you're using nitric oxide therapy, then you're at a greater risk, of course, because you're not going to have the benefit of having a huge area where there's adequate ventilation that's going on. So again, some authors will say, definitely you got to have a scavenging system. And others will say, you're fine as long as your overall ventilation system is working like it's supposed to. Now, half-life of inhaled nitric oxide is pretty short. As you see, only about 5 seconds. And that's mostly because of the fact that once it's in the blood, the nitric oxide will, of course, quickly combine with the hemoglobin and give you methemoglobin. Now, what if you're already taking a medication that's going to cause more nitrates to build up in your system, some type of nitrate-based drug? Then that means that you're definitely at a risk now of developing methemoglobinemia. Now, how much hemoglobin is too much? It always goes back to your individual facility. Some will say that as long as your methemoglobin levels are less than 5%, then you should be okay. But then the minute that your hemoglobin levels in your patient is greater than 5%, they would expect you to start to titrate your nitric oxide therapy and start turning it down. Now, I think we've had this before in another somewhere when we were talking about methemoglobin back in one of those chapters in Desjardins. I used the same picture here just to kind of show that depending on the level of methemoglobin that's in your blood, it can take on almost like a brown chocolate type of appearance. So it's kind of obvious if you take blood from someone who has methemoglobinemia, it won't look red. It's going to look almost brownish. And these are different shades that we have here. Can go anywhere from 1 to 3, really, compared to 4, which is of course like your normal bright red blood sample. And then I included this guy here. He did not get diagnosed with methemoglobinemia. What he did was he had some type of skin condition. I can't remember what it was exactly. They called him Papa Smurf. He was on a lot of the talk shows back in the day when they finally when he brought some light to this condition. He was using some type of silver, some type of lotion or something that he was rubbing into his skin, and it had silver. And he did it for years. And over years, he literally took on this color. He became a Smurf, more or less. That's why they call him Papa Smurf, I think. But I included this here just to say that in a really, really extreme cases of methemoglobinemia, you could end up with profound cyanosis, but it probably wouldn't look like this. Now, on to our next gas mixture here, helium and oxygen, of course, Heliox. And we start talking about some of the basic properties of helium, then we know that compared to hydrogen, helium will be the next lightest gas that's out there. And helium is something that you can't make in the lab. I mean, you can, but it takes a lot. And for all the effort that you do, you don't get that much helium. Helium is mostly going to be found in your underground areas, like where there's little pockets of helium that's still trapped, because from eons ago, something ended up in the soil and then it started to decay. So it was like radioactive decay over years, like uranium as it breaks down. It gives off helium atoms. And and then the helium atoms will get kind of like trapped in these little areas underneath the ground. And so when they go underground and they start drilling and digging, they'll sometimes accidentally find pockets of helium. And other times they're looking specifically for those pockets of helium. So they'll have like caves in different places, like different states and just different areas where they have gotten lucky and they found helium. And these places, I can't remember where the most caves are located, but I know that I think New Mexico's got a lot of them. And Texas, I think, has a lot of these caves. And again, it's just kind of like all over the place. And at one point, we had a helium shortage. And I think it was back, and I want to say the late 90s, maybe late 90s, almost going into 2000. And when that happened, the priorities were with the helium that we have stockpiled. We want to make sure that the people who really need the helium are going to be able to get the helium, which meant that all of your little outlets, like say like Party City and other places that would sell helium, or you go to a place and get a balloon or get balloons, they weren't being supplied anymore. It was the hospitals. The hospitals were taking like the high priority. Hospitals and research labs and even NASA. Was NASA still active back then? I don't remember if they got deregulated by then, but either way, why would the hospitals receive priority with helium? And it's not just the hospital, it's mostly the radiology department. And the radiology department, we know that's where you're gonna get your MRI and your CT done. And MRI machines, because they use electricity, of course, to generate electricity and magnetism. So the electric current is going to power this huge magnet. And anytime you're using that kind of current and those levels of current, that machine gets extremely hot. I mean, we're talking like almost nova type temperatures. But what they do is to keep the machine from completely overheating and burning up, they have to use a helium liquid. They have to have liquid helium, and liquid helium is extremely cold. It's colder, I believe, than liquid oxygen. And so these MRI machines go through a lot of liquid helium, especially if there's a busy lab and they're doing like lots of these MRIs. And again, CT machines as well, they get hot and have to be cooled down. So that's why during that shortage, they always it's like triaging who's the most important people who need this helium. And it was, of course, hospitals right there at the top of the list. And it was a concern for a while that we may not have enough. Okay, now, last thing here, of course, helium doesn't really like to react to other things. I mean, it can react with other elements, but it doesn't like to, because it's considered to be like a noble gas. And then when we look at its overall properties, it's very viscous, but at the same time, it's not that dense of a gas, which is why it works so well for our therapy when we use like Heliox. And then just a little bit of the history here. A lot of these things have been experimented with for a long time, like before it became popular. But back in the early 1900s, that's when they really started looking more into using like a mixture of helium and oxygen to help someone who was in distress. All right, so again, lighter than air, so not very dense. When you think about what's in air, like oxygen is in the air, nitrogen is in the air. And the way that it behaves, it almost moves like a very thick liquid, almost in a sense. But when you mix it together with oxygen, you're creating something that's like almost a third of the weight or the density of just the air by itself. All right, now, so again, we exploit the last bullet point. We're trying to make sure that someone who's having a hard time breathing, they don't have to work as hard to get their oxygen into the airway. So that's the whole point of the helium being much lighter or less dense than, say, the oxygen. And in the end, everything just kind of like ends up moving faster because of this like property of helium. All right, now we're not going to really do any calculations with Reynolds number. Reynolds number is the principle behind the helium and oxygen. So larger diameter. So of course, this is just a universal symbol for diameter. So larger diameter in the airways would mean that there's going to be more turbulence, because we know inside of the airways, there's going to be a mixture of turbulence. Some areas are going to be a little bit more turbulent in other areas, and then some are going to be a little bit more smooth or laminar. But if you've got a larger airway and there's more turbulence inside of that airway, then that means that because of all this turbulence, which creates like back pressure, you're going to need a higher pressure gradient to keep moving it through all of that turbulence, or to keep moving the gas through that airway. And so what Reynolds number is saying is that you got to look at things like how fast, or how the faster the flow, of course, is going to determine how much more turbulence you're going to experience. So not only the flow, but also the size of the airway, the diameter, and then the gas itself. How dense is the gas that we're talking about? And then all of that divided by the overall viscosity. So then you get these values. We say that anything with a Reynolds number less than 2,000 or less than equal to 2,000, then that's good. That means you've got smooth flow, and you don't need as high of a pressure gradient to get that air to travel through the airways, or to get it to move through the airways. So that would be the equivalent of saying breathing easy. You don't have to breathe as hard if you've got a Reynolds number less than 2,000. But then anything more than 2,000 is considered to be definitely turbulent. And that's where we go back to saying it's going to take a lot more of pressure to get the air to go through that airway. And that means working harder to generate that higher pressure gradient. So all your respiratory muscles are going to have to work much, much harder. So if you don't want your muscles to have to work that hard, because we know when it comes to work of breathing, it's just a matter of time before you fatigue. Your diaphragm will fatigue, and all your other muscles will fatigue. So our goal is always to try to make it easier. So to decrease your work of breathing, you need to decrease the pressure gradient. And if you have a smoother flow, or you've got like a Reynolds number less than 2,000, then that's what's going to accomplish that for us. And again, we're just looking at the extremes here. Less than or equal to 2,000 is laminar. Greater than or equal to 2,000 is turbulent. But just always remember, there's always areas that's going to be mixed. So there's like an in-between as well. Now, here's a little short case that we have when it comes to asthma, which is, of course, like one of the most common reactive airway problems that's out there. So let's say that that the child ends up having an asthma attack. And we know with asthma, the younger their child, the younger their child, the less time that you usually have to intervene and do something, just because of the fact that compared to say an older person, adult, airways are going to be smaller. So if you already start off with smaller airways in general, and then they start to swell and constrict, then time is definitely of the essence. You've got to work really fast to try to get them some relief. So you got the child that's having their asthma attack, and then they get the bronchoconstriction. And this could, of course, usually is related to some kind of allergic response, some allergen that either they have identified or they haven't identified. And then not only do you get the bronchoconstriction, but because there's an allergic response and all these other chemical mediators are being released into the bloodstream, then you're going to get your immunity system involved, and you're going to end up with the inflammation. And then with the inflammation, there's going to be some mucus or increased mucus production as well. So really, looking at two-part problem, mostly looking at the bronchoconstriction with the muscle itself starting to constrict, and then you're looking at the swelling of the airways as well. And now this combination, of course, means that you're going to have much smaller airway diameter, much, much smaller. And that means there's going to be more resistance. Now, you still need to breathe. You still have to ventilate and oxygenate. Now you just have to work harder to get the air to move through those tiny, tiny, tiny little airways. Now, as they're working really hard to try to get the air in and out in this asthma attack, then that's going to lead to even more turbulence. And it just kind of like it's not going to get any better until you can get the airways to dilate again, or you can get the immune response to stop. You can get so you can get the swelling to go back down. And then as far as the breath sounds, we usually will associate wheezing with asthma. But just be aware, and we'll talk about cardiac wheezes again later, and I think in the other course. But I'll just say it now that sometimes wheezing is not because of asthma. It could be because your patient has acid reflux or gastric esophageal reflux disease, GERD. And that's what's now irritating the airways, and then that could cause them to be wheezing as well. Or again, it could be like a cardiogenic type of wheeze, or cardiac wheezes, where you have someone who's got, say, like left-sided heart failure. And if they've got CHF, then that usually means there's a lot of fluid that's not moving to the left side of the heart anymore. It's all kind of like backing up into the lungs. And then with the fluid inside of the airways, that's what's creating the narrow diameter. And then that's what will give you the wheezes. So that'll be like the classic, the patient has CHF. I listen to her breath sounds and I hear wheezes. But again, it's not asthma, those are cardiac wheezes. Or the patient has GERD and they've been having a lot of reflux. And then that stomach acid has been irritating the airways as they've been aspirating some of that. And now they end up with wheezes. So now, you're probably going to only see the 80-20 and 70-30 concentrations of Heliox, but they do make 60-40 as well. So it just all depends on your hospital and what they're ordering. And when you go between one or the other, what makes that decision for you is the patient's saturation and oxygenation, usually. Because say like in the case of 80-20, 80 parts of helium and 20 parts of oxygen. Now, if they're not really doing that well with saturation, they may not be able to tolerate this 80-20 because they need more oxygen. They need more than 20 parts of oxygen. So then you may have to now sacrifice a little bit of the helium, or at least the benefits that you'll get from the helium, and go down to, say, like a 70-30 concentration. And now with 30 parts of oxygen, that should be hopefully enough to maintain their oxygenation and saturation. And then again, with the helium being at a 60-40, you're really now sacrificing the benefits that you'll get with the helium, because you're pretty much now just giving them oxygen. It's almost like a half and half. I mean, 60-40 is pretty much it. You're not going to see any company producing a tank that'll be like a 50-50 with helium and oxygen, because again, people like, what would be the point? So it's all about the more helium that you can provide to the airways, the easier their work of breathing should end up being, because of, again, helium's properties: less dense, more viscous, and overall the gas mixture ends up being much lighter. So your driving pressures are not going to be as high to get that gas mixture to go into your airways. Now, we use Heliox for different reasons. Mostly we'll use it for, say, like you've got someone who maybe isn't responding to the bronchodilators. You've got someone who's got really, really bad asthma. And you can wait a little while. I mean, you can continue to give bronchodilators and then just wait and see if there is going to be any improvement. But then sometimes you know that they're going to just continue to work really, really hard, and you're trying to decrease work of breathing. So then that's when you would want to consider maybe just getting them set up on Heliox. A lot of times the Heliox will be stationed right there in the ER, maybe in different ER rooms, like maybe in the trauma rooms or something, or who knows where. They may just have them there stashed away, and then they'll be collecting dust, because therapists don't remember. The ER physician is definitely probably not going to be thinking about it. In fact, it's usually you would have to go to the ER physician and say, can we order Heliox for this patient? And if the ER physician trusts your opinion, they usually do, they'll say, okay, how much do you want me to order? Because they're probably not going to know the difference between an 80-20 Heliox versus like a 70-30 or a 60-40. So then they'll be expecting you, because you're the expert on this stuff, to come up with the right concentration that they can order into the chart. Now, as far as the colors, we know, at least in this country, green will represent oxygen, and then helium will be represented as brown. And I included these here to show you that there are dedicated devices that can be used with Heliox tanks, meaning that here is an O2 blender, but it's not an O2 air blender. It's a helium and O2 blender. So it's calibrated. It's already calibrated to deal with the fact that helium is so much lighter than oxygen. Because if you ran this through a normal blender, things are going to be a little bit off. And then here's another example where we've got a regulator that would go on an E-cylinder. So with that E-cylinder, that little small tank, again, it's designed just for that Heliox mixture. It's brown and it's green. Now, will your facilities have these? Probably not. They may have, and they may not. That doesn't mean that you still can't use your regular oxygen regulators with this Heliox mixture, but you just got to know that it's not going to be accurate anymore. And then the same will go for the flow meter. Here's a dedicated flow meter just for Heliox. If you use this with a regular, if you just use this with, say, like oxygen, then it's not going to be accurate. So it's tailored just for Heliox mixtures. And it's compensated for that reason. And then one last thing I'll say about the Heliox mixtures here. This is about as far that we go as far as the more oxygen, less helium. And this is as high as we'll ever go with the helium and oxygen. So you'll never see a company produce a tank that's say like 90-10, because at that point, you're almost given just pure helium and no oxygen. So this is someone who's going to have some oxygenation problems for sure. So that would be considered like a hypoxic gas mixture. You're literally giving them some gas to breathe, but it has no oxygen. And as we know, what can your cells do with helium as far as metabolism goes? They can't do anything with helium to produce more ATP. They need oxygen to do that. So we can go way overboard. I guess that was my point. If we were to try to manufacture a tank that was like 90 parts of helium and 10 parts of oxygen, because again, you're now going to create definitely some oxygenation, some challenges for this patient. All right, and then one other thing. So the aerosol particle deposition, if you use this tank and connect it to their nebulizer when they're taking their bronchodilator therapy through the handheld nebulizer, then that's going to do two things. It's going to still make it easier for them to breathe. So the work of breathing is still going to be not as high. But then also, the way that the Heliox will break apart your medication, meaning like how it will break it apart into these little aerosol droplets, they're going to be really, really, really small compared to just using oxygen to nebulize your medication. And because they're now much, much, much smaller little aerosol particles, then now they should have the opportunity to go even farther into the airways. So think like MDI. Now, MDI is just a fine, fine mist, really, of medication compared to, say, like a handheld nebulizer, which is more so like bigger particles. And bigger particles tend to not make it as far down into the airways, at least the lower airways. Smaller particles have a much better chance of getting there. And that's usually where the problem is usually in those lower generations where the airways, the really, really small airways, the terminal bronchioles, is where the problem usually is when it comes to bronchoconstriction. So now, here's our facility not using any special design equipment for this Heliox mixture. So they're just still using the standard O2 regulator, and this is for the H tank here. So what we have to consider is, depending on just what our concentration of Heliox is, we've got to do a correction factor. If we really want to know how much or how fast this mixture is moving out of that tank. So then these are the ones that we just memorized to say that if it's an 80-20 mixture of Heliox, whatever your flow meter is set at, that's not the true speed. That gas is really coming out almost twice as fast because it's a Heliox mixture. So 1.8, close to twice as fast. And then a 70-30 would be almost 1.5, a little bit more than 1.5 times faster than what the flow meter is saying. And then the same goes for 60-40, almost 1.5 times as fast. So now this is purely for like for educational purposes. Will you do this at the bedside? Chances are very unlikely that you would do this unless you were making up a new policy or something in your facility, and this will be maybe part of that. But in general, this is just to kind of show and prove and demonstrate that you understand the concept, you understand the principle behind it. So here's a case where the orders say to give 70-30 Heliox, and for whatever reason, they want to limit the amount of flow coming out of this system. They want it to come out at only 8 liters per minute. Now, because this O2 flow meter is not calibrated for helium and oxygen, it's only calibrated for oxygen. If you set your flow meter on 8, it's going to be faster than 8. So then what we need to do to figure out exactly what we should turn our flow rate on, or at least our flow meter? Again, if you turn this, you switch this to 8, your flow meter to 8 is going to be violating your orders. Your orders are just, for whatever reason, saying that make sure that the total flow is 8 liters per minute, and that's it. And again, this is purely theoretical. You'll never probably encounter this type of order. It'll just be give 730 heliox and maintain saturation, blah, 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 and that'll be pretty much that. So back to this right here. There's got to be a way we can figure this out. So if we put on our thinking caps, as you know, our grade school teachers used to tell us, put on your thinking caps and look at the information that we have in front of us. There's got to be a way that we can figure this out. So the question is, what flow rate will you need to turn your flow meter on so that that way your heliox mixture is coming out at a total flow of only 8 liters per minute? So I see 12.8. So if we turn our flow meter on 12.8, that heliox mixture, which is lighter than just pure oxygen, is going to be coming out even faster than 12.8, even faster. It's going to be coming out at practically 20 liters per minute. And in order to say it should only be coming out at 8 liters per minute. 5? Okay, how do we get 5? 5 looks like it's going to work. So how do we get to 5? What will we need to do mathematically here? 8 divided by 1.6, correct. Because what would you get if you multiply the 5 times 1.6? This is essentially going back and forth, back and forth. If you multiply 5 times 1.6, shouldn't you get 8? Which would be the total flow. That's how, even though the flow meter is set at 5, that mixture is really coming out much faster than 5. It's coming out at 8 liters per minute because of the, again, the properties of helium, or the properties of the mixture, helium and oxygen. And then if you were to divide the 8 by the 1.6, the correction factor for 70/30, then again you get 5. So this is just a mini exercise, and can you understand the whole point of this? What's the whole point of having these correction factors? The point is that heliox is a much lighter gas when you combine helium with the oxygen. So in a sense, we're using the helium to ensure that the gas can make its way to the alveoli. And while you're doing this, you're not having to work so hard anymore. You still have your issue, like maybe you still have the bronchospasm that hasn't really resolved yet, or you still have the swelling that hasn't really resolved yet. Or what if you've got someone who has an upper airway obstruction, like some type of tumor process in their upper airway? And right before they get surgery, you may have to give heliox. So that way they can continue to maintain a good saturation and not have to work so hard. Because without having the Heliox, breathing in with that kind of an airway problem, if you got that like that really bad tumor in your upper airway, you're gonna have to work really hard to get the air in. So that will be another benefit of using Heliox. Any kind of like major upper airway obstruction. And then for these examples that we've been looking at, small airway obstruction, meaning asthma, bronchospasm, swelling, that kind of thing. Okay, so any questions on what flow rate is necessary? And again, you can do this with any example. You could have made this. The orders are to give 80-20 Heliox and make sure that the flow total is only 10 liters per minute. That'd be the same process. You'd have to take the 10 liters per minute and divide it by the correction factor for 80-20, which would be the 1.8. And then that would be a little bit more than 5. Okay. So now when you give Heliox to someone who isn't intubated, then you're using your non-rebreather mask is what you're doing. Because any kind of gas mixture that you give to someone who isn't intubated, your best bet is to use the non-rebreather. And doing it with a cannula is not going to be as beneficial because the cannula doesn't have a reservoir. The non-rebreather has that built-in reservoir to ensure that you're always going to have the right concentration of your Heliox. With a cannula, you're diluting your mixture by breathing in room air. So you're entraining room air as you're breathing your Heliox through the cannula. So then now you're going to get a much diluted concentration of Heliox, which is, again, not really going to benefit the patient. Now, if you have to intubate, sometimes this saves you from having to intubate. You've got someone who had really bad asthma attack and you were trying not to intubate, then a lot of times the Heliox would come in and save the day. And if they got admitted to the hospital from the ER, the Heliox would go with them. That's how it's usually done. Just transport the tank to their new room and have them to continue using it for oxygen therapy and for connecting it to their nebulizer treatment when they need to take their nebulizer treatment. Now, when you connect your non-rebreather to the Heliox tank, don't expect the bag to fill up completely like it would if you were, say, just using your standard oxygen. Just again, know that they're still getting their Heliox mixture and the bag is still holding that mixture inside of it. Just may not fill up completely. So just don't expect that to happen, especially depending on what flow rate that you've got your flow set at. Now, again, with the ventilator situation, now let's say we could not avoid intubation. We had to place the patient on the ventilator. Then they will say, let's just, of course, discontinue the Heliox. But some manufacturers of these ventilators have recognized that patients may still benefit from having the Heliox while they're still on the ventilator. So that meant that they had to figure out some way of integrating the Heliox with the ventilator. And then that way they can continue to still receive that therapy. But if you didn't have one of those special ventilators, we'll see that it can create havoc with the ventilator itself. And then this thing about air trapping, then of course, if you can continue to give them their Heliox while they're in the ventilator, then that would overall help to minimize the chances of them having the dynamic hyperinflation that happens when you have air trapping. All the air doesn't get exhaled out, and then here comes another breath on top of that. And then all of that doesn't get exhaled out, and here comes another breath. So if you can kind of work on those airways and get them to relax and dilate, then that should prevent the air trapping. Now, before we take our break, let's just take a quick look at this video. It's more along the lines of it's almost like a commercial. This company really wants you to think about using their system, but it still demonstrates how simple setting up Heliox could be. And it's not as complicated as people probably would think it is. So let's take a look at using Heliox with a Vapotherm. So now you know Vapotherm is a cannula system, more or less. I mean, it's not a standard nasal cannula. It's its own like dedicated cannula that you would use with the Vapotherm. But with this company, Medipure, they're going to show you how you can use Vapotherm and still deliver Heliox without having to think about using like a standard like non-rebreathing mask. So let's get that going. So it's just a couple of minutes here. Okay, so I think we get the point that when these companies come up with these different types of systems, the goal usually is to streamline things and to make it so much easier without having to use a whole lot of extra adapters that you got to collect yourself and then just kind of like, rig things up. So it all should work pretty, again, seamlessly. Because ordinarily, you would probably never thought about trying to use Heliox therapy with a high flow nasal cannula like Vapotherm. But again, that's one solution. Okay, so let's go ahead. It's like 10:55-ish. Let's just go ahead and take a 10-minute break and continue from there. Okay, so we're back. So this is what I was referring to when it comes to manufacturers making sure that if you want to continue to use Heliox therapy for the patient on the ventilator, then you can just connect through some type of valve, some built-in valve that they have, or port or inlet or whatever you want to call it. So if you don't have this special adapter that's built into your ventilator and you still try to use Heliox therapy just by introducing it into the circuit somewhere, like kind of similar to like when we're looking at the inhaled nitric oxide or Inovent with the gas injection module right before the humidification. If you were to kind of do something similar to that with a ventilator patient, then what will happen is all of your measured values are going to be like haywire. The machine is not calibrated for anything except oxygen and air as far as the density and the viscosity and that sort of thing. Now you introduce helium into that system and your numbers are going to be really all over the place. The machine will be confused. It won't know what the exhale tidal volume is. It won't know what the tidal volume is that is set to deliver. It's not going to be able to really track how fast, like your peak flow rate. It's not going to know because of this lighter gas mixture. So to keep that from happening, you would have to select a machine that has a dedicated integrated Heliox type of system. And it kind of looks almost like the video that we were just looking at, where you just take the hose and connect it into a port, and you just look on the back of the machine, and then that's where you can connect your tank. And that way, now because of that Heliox being bled into or being introduced into the port, the machine will know how to compensate for that. And your numbers that you get on the monitor are going to be accurate and they won't be fluctuating all over the place. Now, hypoxic or hypercarbic gases, they have the same purpose. If you give a gas that has less oxygen, or if you give a gas that is just purely carbon dioxide with no oxygen, you're trying to create some kind of vasoconstriction. And again, on purpose. Similar to what I was saying earlier about when you are dealing with some type of like congenital heart defect and you want to redirect blood flow, then you're going to have to, of course, make vessels now constrict so that will cause the blood to go into a different area. So with a hypoxic or hypercarbic gas mixture, we're thinking about maybe say like a baby who was born with some kind of lesion, some kind of cardiac lesion, and there was a lot of hypoxemia, and there was a lot of like cyanosis as well. So this ratio that they're referring to here, so just QP, or sometimes you'll see the little dot over the Q's here. So this is just looking at, not to be confused with shunt. So we use QS to mean shunt before, but this time we're looking specifically at just like pulmonary blood flow. And then we look at it as far as the pulmonary system versus the systemic. If the ratio is equal, then everything is fine. I mean, things are working the way they're supposed to, as far as, blood circulating to the lungs, receiving oxygen, and then returning back to the body. Now, if you've got a ratio that's greater than 1, then what you would typically see is the baby is considered to be, okay, there's still a problem, but the baby's not going to be cyanotic. So when we get into the cardiac problems chapter, then we'll put more emphasis on that as far as the pink babies versus the blue babies when there's cardiac problems. But if your QP-QS ratio is greater than 1, then that means that your pulmonary perfusion is way more than your systemic. And then we say that that's just systemic hypoperfusion that's taking place. You typically see like skin is kind of cool and they're not blue, but they have oxygenation problems. And if your QP-QS ratio is less than 1, then that means that you've got too little pulmonary perfusion compared to the systemic. And then that would just mean pulmonary hypoperfusion. And then with these, you're definitely going to see the cyanosis. And they, as they say, as far as skin temperature, the skin will usually be warm, but they're going to be blue for sure. So it'll be obvious in this case, but then in this case, if you're just looking for skin color as an indicator, it's not going to be obvious. So you'll be wondering, like, why is this baby desaturating so much? And then you get to the bottom of it, and you'll see that there's a congenital heart problem that never got detected, possibly, or maybe something that's newly developing. So now, how would you make a hypoxic mixture or a hypercarbic mixture? So let's just look at the hypoxic mixture, because we'll talk about, of course, this being like one of the options that we have for treating like the hypoplastic left heart syndrome type of cardiac defect. And what you want to do here is your goal is to try to get the pulmonary vascular resistance to go way up. And if that happens, then of course, blood is going to start to be rerouted. And to do that, you need to make the patient hypoxic on purpose. So this would be one of those cases where you're going to have to give them an FiO2 less than 21%. And then you ask yourself, how in the world can you get less than room air? Because the air that we breathe is about 21%. It's 20 point something, 20.89 or something that rounds to about 21%. So then if your goal is to give, say, like 14% O2 or 15, 16, 17, then you've got to set up some kind of system that's going to be able to allow you to blend some gases. And so let's look at this example here, where they're using 2 different blenders so that you can control just how much FiO2 that you're giving as far as, less than room air. And the explanation that's given here first is just saying that you turn the blender at 21%, and then you pass in some nitrogen or carbon dioxide, and then you've got your hypoxic mixture. But this picture kind of expands on it a little bit just to kind of show you what's really happening. So now, let's just take the first blender right here. The first blender is connected to an oxygen source, your 50 psi, and it's also connected to a nitrogen source. This may be a nitrogen tank. And you turn the knob to 21%. So if you do that, that means that instead of blending the nitrogen and the oxygen together, it's pretty much just going to pass the oxygen straight through. So there's the oxygen coming through, and it'll just end up passing straight through. And depending on which is connected to which, we can't see which is connected to which exactly. So this was connected to like where the O2 normally would be connected, and this is connected where the air is normally connected. Let's do it that way. Let me write a note here to say that this is the normal air connection. So what that means is that let's not pretend that this isn't nitrogen. This is just plain old air. Like when you connect your ventilators into the wall, you've got the yellow air connection, and then you've got the green oxygen connection. So now let's pretend that the nitrogen is the air, the yellow, and the oxygen is still oxygen. As far as this blender goes, if your goal is to give like a 50% oxygen, when you turn the dial to 50, it's going to take like equal parts of oxygen and air and mix it together so that you get 50%. Because O2 by itself, we know is just pure oxygen. It's 100% FiO2. And in air is 21%. And that's why we have the blender there to kind of fine tune just how much of a concentration that we want. So like in the case of just pure oxygen, you turn your dial all the way to 100%. And then what will happen in that case is you turn this to 100. Now, just nothing but oxygen is going to pass through the blender. It's not even going to mix it with any of the air at all because we want just pure oxygen. And then vice versa, if you don't want to give any oxygen and you just want to give pure air, which is again 21% oxygen, you'd have to turn this little knob to 21%. And so that way, instead of taking that pure 100% oxygen and mixing it with the air, it's just going to be all air that passes through the blender. So that's why I wrote, let's just pretend like this is where the air would be, because otherwise it wouldn't make sense otherwise. Even though they made the colors the same here, this is not the case unless they hook these up backwards. But either way, we're just going to follow what we know would happen. So let's have this now be definitely nitrogen, and then that's oxygen. And now that we've got the knob turned to 21%, this is going to be blocked. The oxygen is not going to be pulled, or it's not going to be mixed with the nitrogen. It's going to be all pure nitrogen that's passing through. And now let me write here that pure nitrogen will be passing through because we have it set to deliver just 21%. Now, you've got pure nitrogen and you've got air connected to the next blender. So it's the same kind of thing that we have here, except we don't have oxygen anymore. As a mixture, we're going to mix air and nitrogen together with our blender here. So now if you turn this to 21%, so then that would mean that it would just be pretty much all air that would make its way, and then the nitrogen won't get mixed with it. So that's how it would work if you had these set up the way that you normally would have O2 connected and then air connected. But again, the way they did this picture, they made it so that instead of being nitrogen that passes through, you notice that this color looks the same here. They made it such that oxygen was the one that passes straight through. Again, this will really depend on how you have it connected. Really, because again, all you have to do is just swap them in a way that instead of connecting to where you normally would connect the oxygen, you're connecting that to the nitrogen. And then where you normally would connect the air, you connect that to the oxygen. So that's a little wonky. But really, this is what's supposed to happen. What's supposed to happen is if you take just room air and you add more nitrogen to that room air, Dalton's law says that you're now going to make the nitrogen levels increase, or the partial pressure nitrogen is going to increase. And if the partial pressure nitrogen goes up, the other gases have to go down, meaning like oxygen. Oxygen can no longer be 21%. If nitrogen is now, say, 85% instead of 79%, your air, then that means that the oxygen is going to have to be lower. It's going to have to be like maybe about 15%. In fact, when you start doing something like this, you will usually end up with an FiO2 anywhere from like around 14% to about 20% or 21%, which is why you have to use this second blender to dial in your concentration. Like, do you want 15%? Do you want 16? Do you want 70%? And of course, this is gibberish. This won't make sense because you're turning this to say like 22 or 23, when really that would mean your FiO2 is going to be like 17% or 18%. You'd have to take an O2 analyzer and measure how much oxygen is being delivered. So again, this is just a method, one method that you would have to use to get a hypoxic mixture. All right, so again, I wrote this is where the air would normally be connected, but they have it reversed really in this picture because it just follow the actual gradient here. This looks to be like really dark. I couldn't find this picture in color. This was the only picture I could find, and nobody else has really shown any kind of setup like this. But this is dark, and that's kind of like a lighter, and then you notice that all of that passed through. So pretty much all the oxygen passed through here. And then you're now taking the oxygen and mixing it with the air. But again, that wouldn't make sense. So it has to be pure nitrogen. So I really would like this picture to be a little bit more clear for you, but really just think about Dalton's law. Dalton's law will answer this question all the time. In order to make a hypoxic gas mixture, where you're going to now try to deliver an FiO2 less than 21%, you've got to make nitrogen higher. You got to have a higher concentration of nitrogen. And then that way the O2 is going to have to decrease. Now, anesthetic gas mixtures. So these have been experimented with, for a while. They've been looking at using this as like something to treat asthma for years, but you just don't commonly find it being done because of the training that's necessary and then all the equipment that's going to be necessary. But let's say the NBRC has got everything in place like that they should. They should got all of the parts in place, and they've got the scavenger system in place, and the therapists are all trained. Then this could be something that you can consider. Like the asthmatic who's not getting any better, you consider doing like maybe Heliox, and then the Heliox maybe really wasn't working. Then you could consider like using one of these anesthetic gases here. And this is a picture here just to kind of show you the anesthesiast card. And it's by Draeger. Again, Draeger's got a lot going on besides just ventilators. Now, the ventilator is built into the card. As you see, here's the screen. We're in, what mode is this? IPPV, which just stands for intermittent positive pressure ventilation. So here's all our values here. Here's our knob to make our selections. Tidal volume is set at 600. FiO2 is 50. The respiratory rate or frequency is set at 10. ID ratio is 1:2. PEEP of 5. So either way, this is a built-in ventilator in the anesthesia card. And then also, this is a built-in station for delivering those anesthetic gases. Because sometimes they'll use just gases to do their cases, and then other times they will use a combination of the gases and the other drugs like the propofol and paralytics and et cetera. And all of that will be used to, of course, maintain complete amnesia and anesthesia throughout that surgery. And then this is the anesthesia bag. So if you've got someone before you intubate, You're going to have to give them some manual ventilation or hyperoxygenate them. You're going to have to use this little flow inflating bag here that's built onto the anesthesia cart. That's why they call it an anesthesia bag, because this is where it started from. That flow inflating bag that we looked at in the lab with the baby and ventilating, it's the same principle. It's pretty much the same bag. It's just a smaller version of that bag. And of course, here's the ventilator circuit itself, the tubing. Of course, the patient's over here intubated, more than likely, or and maybe they just got a mask on right now. And of course, got their built-in monitoring of all the vitals and hemodynamic parameters and et cetera, et cetera. And there are more than these. I mean, these are like the 4 that they included here: halothane, oxyfluorine, enflurane, and sevoflurane. But there's others that they will use as well. And each will have its like benefit over the other. And they all are pretty bad as far as like if they become toxic, if they reach toxic levels in the body, you can end up with a lot of issues, like organs are going to really have problems, the liver, the kidneys, and your central nervous system, and et cetera. So they have to really monitor these levels carefully. So now for your asthmatic patient, the halothane, well, really all of these anesthetic gases, they do so many things in the body. They act almost like bronchodilators, meaning that they will literally bind with the same beta-2 receptors that your albuterol would bind to, or your Xopenex will bind to. And not only that, they also almost act like anticholinergics. They will block vagal responses, meaning that they're going to block your acetylcholine from binding to those nicotinic and muscarinic receptors. They also will almost act like nitric oxide, meaning that they'll get into those muscle layers of the vessels, of the pulmonary vessels, and make them dilate. And then they'll also block histamines. And that will be definitely beneficial for someone who's experiencing an asthma attack, because the more histamine that's released in an asthma attack, the more airway swelling is going to happen. So these anesthetic gases will do that. And then they'll also, I mean, they just do so much more. They only listed 4, but there's like a list of things that these gases are doing. And again, their purpose usually when they're given during surgery is to slow the breathing down and relax them, and or in some cases make them completely stop breathing and give them no pain sensation at all, and complete unawareness and amnesia when they do wake up. But then, and then also these are some of the other benefits. So can we really reap the benefits of these gases for our really bad asthmatic patients? And the answer is yeah, but again, we got to be careful with them. So the first thing is, let's say that you're going to get training on how to use isoflurane or halothane or whatever the case is. You have to first kind of like understand how these vaporizer chambers work. And what they are is essentially just a means of you insert or you add your medication, which is a liquid. So like halothane, isoflurane, they all come as a liquid. And then you inject the liquid into the chamber, like here's a little port, or there's the port for, this is blue is desflurane. So you add your liquid medication into the port, and then you'll see like your level start increasing here, like this little watch window. And then once it reaches its full level, you of course close the port back off, and then you dial in your concentration that you want to deliver, which means that it has to have a gas source connected to it. These vaporizer chambers are under pressure because these different anesthetics are very volatile, meaning that they evaporate very quickly and very easily. I think one of them, if you open it to room air for too long, it'll all just vaporize out and it'll be gone. So each one of these chambers has its own special little pressure, built-in pressure settings to maintain a certain pressure. So that way, all your medication doesn't end up just evaporating out just like that. And you need what's called a rebreathing circuit. They'd have to train you how to set up one of these rebreathing circuits. And the main thing about this rebreathing circuit is you've got to have some type of system in place that's going to prevent you from rebreathing your own CO2. And what that would look like would be some type of soda lime canister. And that soda lime, what it'll do is it will literally combine with your CO2 and the water vapor in your exhale breath, and then it will essentially neutralize it. So that way, when you breathe, when you take your next breath, it says fresh O2 or fresh gas source or inflow. So this is like our O2 that we're inserting into this circuit. And now the patient breathes and exhales through the exact same circuit. And now here's a soda lime canister. Over time, this can only absorb so much CO2 and so much water vapor before it's considered to be not useful anymore. It changes color. The calcium carbonate, I think it is, one of the compounds that they're using with these soda lime canisters, it'll start to take almost like a bluish or purplish kind of color. And what will happen is it'll slowly happen over time. Like maybe this part is now purple, but this is still white, so it's good. And then maybe once the purple level reaches about here, it may be time to switch out this canister because it'll just be a matter of time before it's not going to work anymore. And let me back up to this slide right here to show you that. Look how big this soda lime canister is in this anesthesia card. So they always have to, like before any surgery, they have to keep a close eye on these things to make sure that they're still fresh and they still look like brown, whitish, and that there's not a lot of like color changing here, like a blue or purplish kind of color. And one other thing, we have these soda lime canisters in our PFT machines as well. When you have a patient go to the PFT lab and you connect them to that machine, some parts of that PFT, you're going to have them just rebreathing their own breath, like over and over and over again for a period of time, like nitrogen washout test or helium dilution test. So once again, if you're the person who's in charge of the machine and doing the testing, you've got to always keep an eye on that soda lime canister to make sure it's not exhausted and completely used up. It's kind of like the same concept when you think about your CO2 detector when you use for intubation and confirming that you're hopefully in the airway. And it changes color. It changes from like that yellowish kind of color, and then it changes like that purple type of color once the CO2 has reacted with it. And anything else? Oh, one other thing. This is just something that I remember talking to one of the other instructors at the first job that I had back when I was teaching in LA. And she said that at her facility, they were so cheap at one point, they would have the department was getting them to take these soda lime canisters after they've, been exhausted and they've all kind of like completely changed color. Get them to take the canisters, open them up. Wait, did they open them up or did you take the whole canister and place them in a microwave? But I can't remember those details, but I do remember saying that they would make them put these canisters in the microwave to refresh them and then use them over again instead of just getting a whole new canister and inserting it into the machine. Now, that is not the way that these things were designed. I mean, these were designed to be replaced when needed, not to be placed in a microwave to dry them back out and then put them right back in the machine. And you can imagine that infection control probably had a complete fit over that when they realized what that policy was in that facility. Now, so that's pretty much that. Just know that if you're going to use inhaled anesthetic gases, again, it's going to require definitely some training. You'd have to train with anesthesia and get checked off. And then your hospital's ICUs would have to have the same type of scavenger system. Your hospital's ICU would have to have the same type of scavenger system that the ORs have, where they can plug in the exhaust into these little outlets, so that way nobody's at risk. Because again, these gases are good for what they do, but then when levels are too high in the body, then there's going to be a lot of complications related to them. So that's one, a lot of places you're never going to probably even consider using that, but it's an option for someone who's got really, 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 really resistant refractory type asthma. All right, now surfactant, we'll get started on surfactant here, and we'll talk about just the scientific principle behind what's happening with surfactant and surface tension first. Then we'll start looking at more practical applications as far as if you're going to use this surfactant therapy, who would benefit the most from it. And then we'll just talk more about these different conditions and different type of diseases that you would see commonly in the newborns and pediatric population. All right, so Laplace. Sometimes it's just Laplace and sometimes it's Laplace and Young. They both were given credit for coming up with this principle here. But again, a lot of times we're just going to refer to it as Laplace's law. And all we're looking at here is the surface tension versus the pressure across that sphere, meaning that how much pressure is it going to require to keep that sphere from collapsing on itself? And when you think about basic physics, when you push against an object, that object is literally pushing back against you. If it's not moving, that is, if you're pushing against something and it's not budging at all, it's pushing you back at the same amount of force that you're using. And then when you push even harder, then that's when you may get it to move. Like in the case of a bubble, that bubble, the pressure inside of the bubble is pushing out. And on the outside, you have what's called like the surface tension that's going to help to keep that bubble. That surface tension is going to try to make the bubble collapse on itself. And then the pressure on the inside of the bubble is trying to prevent that from happening. So it's pushing outward, while the surface tension is kind of like pushing downward on it. I guess you could look at it that way. So these variables that we have here, we've got the P, meaning that is the distending pressure. So that's that pressure that's going to keep the bubble from collapsing. And then we've got the surface tension that is actually really trying to cause the bubble to collapse. And then radius being like the overall size. And then this relationship that we have here, P is equal to 2 times the surface tension divided by the radius. Distending pressure is going to be directly proportional to surface tension because they're both in the numerator. But the radius of the sphere is in the denominator. So that would mean that P is equal to 2 times ST divided by R. So these are going to be having that indirect or inverse property and relationship with each other. Now, the point that the author was making at the last bullet point here is just saying that there's going to definitely be more studies done on surfactant and and premature babies. I mean, it's already been established that they do get better in a lot of cases. If you identify early on that you could use surfactant therapy to treat them, then that usually makes the difference in their outcome. But what's the best surfactant therapy out there? And of course, that will depend. There's options. And then how often do you need to give? So those are the things why they have to keep doing studies and doing experiments to kind of see what seems to work better. All right, well, it's lunchtime. So let's say, what is it, 11:45-ish. So we'll be back at 12:30 to finish off this chapter.